Cool. Right, now, we are on to Jamie McAlpin, Jamie Mac, as we all call her. So, Jamie McAlpin holds a Bachelor of Science in Nursing from East Carolina University. Her specialities include coronary care unit, cardiovascular intensive care, cardiothoracic open heart intensive care, Code Blue team, interventional cardiology lab, both for adults and children, and electrophysiology lab for adults and children. In 2014, she began working with Iboga and researching safety and best practices. She also began volunteering with the Global Ibogaine Therapy Alliance, GITA, to co-author the clinical guidelines for Ibogaine-assisted detoxification, which led to her to deepen her research into the medical considerations and risks related to Iboga and Ibogaine. In 2015, she completed training to become an American Heart Association BLS and ACLS certified instructor, and continued working with GITA to develop the first ACLS for Ibogaine and Heart Saver training courses, which were offered at the 2016 GITA conference in Tepoztlán, Mexico. She also presented on the Ibogaine Therapy Ethics and Safety panel discussion at the conference. Jamie is a co-founder of Iboga Safe, an organization dedicated to on-site training and education to reduce harm and increase safety in Ibogaine treatment.
Thank you, Jeremy. You can go ahead to the next slide. So this is just a speech that's basically based on a poster that my partner and I did for the MAP Psychedelic Science Conference back in April. We wanted to appeal to science types, but I'm not a scientist, so this is my first attempt at one of those posters. And we also wanted to appeal to just psychonauts at the conference because it was a very big conference. So we wanted to kind of use this as like a harm reduction tool for the general public. Next slide, please. And that poster's hanging up in the lobby today. So introduction to this. As registered nurses who've worked in Ibogaine treatment, we're aware of practices and beliefs that are not safe and can be life-threatening. We hear these myths from users and providers and just people who are generally interested in Ibogaine. Next. Oh. Disappeared. So our main concept of that poster was that provider training could go a long way to reduce adverse events. So aspects of the safe Ibogaine treatment. You know, we wrote clinical guidelines, and it's kind of it's not full protocol versions, it's just guidelines. And protocols are great when everything's black and white, but in medicine, everything's pretty much always gray, so it's kind of hard to pin down very specific protocols. But you know, you did the best you can. So aspects of a safe treatment: we have meticulous patient screening and selection. That's the first and foremost, one of the most important parts. And then patient preparation. They need to be prepared on all fronts to face what they're about to go through. And emergency response planning is another big thing. That's being a cardiac nurse, that's a big thing for me. And then aftercare, recovery and integration, I think, is just as important as preparation and the ceremony itself. Next slide, please. Okay, so methods for our, I tried to follow like the typical science poster protocol. Methods for this is I reviewed 34 case studies from medical literature, and then there was a lot of research done during the guidelines writing that kind of helped me form my own thoughts about what was causing specifically a lot of the cardiac events, and just our nursing experience and background. Next slide, please. So myth number 1, Ibogaine is safe for treating all dependencies. Detox and withdrawal are very complex, even without Ibogaine added. As an ICU nurse, I saw a lot of the worst detoxes where, the patient had comorbidities, so a lot of times our only choice is to put them in a medical coma and detox them that way, which sucks, and it's not very kind to the body or the patient. And then Ibogaine will not reduce or prevent withdrawal-related seizure activity. This is another big issue because seizures can prolong QT intervals. So when you have someone on Ibogaine having seizures, now you've got two things prolonging the QT interval, there are cases where seizures have precipitated cardiac arrest. So you have to be very careful with any coming off of anything where the withdrawal symptom and the risk is seizure activity. And obviously people with seizure disorders. And then we'll talk, next slide, the use of Ibogaine, which affects the QT interval. This is what makes, this is what causes cardiac issues. So I think someone went over this yesterday, but the QRS complex is the part of the EKG when the ventricles contract the lower chambers of the heart. And then the T wave is where the electricity is getting back to normal to get ready for the next contraction. All heart motions are electrically stimulated first. So first you have an electrical stimulation, then you have the mechanical follow through. As this QT interval, so it goes from the start of the Q to the end of the T wave, this is a very vulnerable period in the heart. I think of heart's electrophysiology like when you go to flush a toilet, you have to wait until the water fills back up before you can flush the toilet the next time. So that's kind of what the heart has to do electrically to be ready to have a normal beat again. If it gets electrical stimulation during this interval, bad things happen. It actually triggers lethal cardiac arrhythmias, which is cause of death in a lot of these case studies. Next slide, please. So we use case studies to debunk this myth, and I know correlation doesn't equal causation, but it does give us clues about risk management. An example of my counting methods, the way I did this was I made nurses' notes on every single study, and then I color-coded things that were repeated over and over, and then counted the totals up. So next slide, please. I'll show you an example of someone who counted for a lot of things on that chart. So this guy was 27, and he had a polysubstance abuse history, 15 years, a laundry list of things. So he actually counted 1 point for each category in that chart because he also tested positive for methadone and benzodiazepines, 3 different kinds. And he had no cardiopulmonary disease previously, and his autopsy report actually listed aspiration pneumonia, which is if someone vomits and then some of the vomit goes down their airway, that can kill a person pretty quickly. But the coroner reports the cause of death as Iboga poisoning. So it's another ding for the naysayers to say, oh yeah, this is dangerous, we shouldn't be looking at this. Next slide. Actually, it was. So, yes, this case was the French case, and because of a result of this guy's case, Ibogaine was made illegal in March 2007. This was a case that occurred in 2006. Yes.
I actually treated a guy who was about that.
Oh.
He told me the guy was using.
Yes, he tested positive. So. Right. Oh, wow.
around, and then the police all arrived. And he was completely, out of it, but it was classed as a murder scene at that point. But he was using.
Yeah, definitely. I mean, he was definitely using still. And there are a lot of deaths. A lot of methadone deaths involve benzodiazepines. That's a very common thing that you see in a lot of case studies of methadone arrhythmias. And methadone is a QT prolonging drug as well. And so you see methadone-related arrhythmias and methadone deaths when they combine with benzodiazepines because you have two sedatives on board. Yes? That's what his providers described to the people, that he ate a teaspoon of iboga. I would think so too, but obviously with drugs in the system, it could have potentiated the benzos and the methadone. I mean, you've got methadone QT prolonger, ibogaine QT prolonger, benzos, possible seizure QT prolonger. You got three things right there that could lead to a really bad event, and obviously it did in this case. And then if he was using directly afterwards, that could have precipitated the entire event. But this was just another case of, the politicians in France used this as ammo to go ahead and outlaw ibogaine. We shouldn't let that happen. But next slide. So I think I skipped a slide. Yeah. So our recommendations, with the first myth is that qualified medical supervision before, during, and after detox is highly recommended because the hearts are very unpredictable, and it's actually a pretty complicated process sometimes ruling out pre-existing cardio disease, because arresting 12-lead EKG is only going to tell you so much. Sometimes you need additional things. You need a Holter monitor or echocardiogram, stress echocardiograms, things like that. So when I used to screen my higher risk patients that came to me with a lot of different cardiac risk factors and maybe like a weird abnormality on their 12-lead, they have to go get a stress echo before we'll touch them. Qualified medical supervision. You need a team that includes several people with medical doctor, RN, paramedic level of training. You need people that know advanced life support. Advanced life support is a team sport, so having one ACLS certified person doesn't really help you a lot. I used to work Code Blue team for my first hospital that I worked at, and we were a 5-man code team. There's 2 nurses, 2 doctors, and a respiratory therapist. So, and even with that, you don't have enough hands. So sometimes you want a 6 or 7-man team, but you need people that understand how to work together in a resuscitation team and have experience. You need people that are proficient in EKG monitoring and interpretation, ACLS certification, of course, and any lay providers definitely need to be certified in basic life support. And then experience with resuscitation. Not all medical professionals have resuscitation experience. So, and you have to be very comfortable with that. Some people cannot keep a cool head during a cardiac arrest situation. And the last thing you want is people panicking. But it used to happen plenty of times when I'd go to the floor for a Code Blue in a hospital, and the nurse taking care of that patient's already freaking out. So not every nurse or doctor is really cut out for resuscitation. And then knowledge of ibogaine pharmacology, obviously. Next slide. And my first question, also, like if I were interviewing medical staff for my Iboga Center, my first question to anyone would be, have you ever run a Code Blue? Do you know how to what is your experience in resuscitation? So myth number 2. This has become a big myth to bust in recent times. Buying online and self-administering with a sitter is safe. You see this all the time if you get on social media or anything. People are like, oh, I ordered this powder or TA or hydrochloride. I'm going to take it at home. My girlfriend's going to watch me. I had a 12 lead EKG. The doctor said it's normal, but it was probably a doctor that didn't even tell why they wanted to get this done. And it sets people up for failure. And it also sets their caregivers up to be traumatized. So this is a big problem. Out of the 34 cases that I reviewed, 10 of them involved self-administration. And a lot of those were in more recent years as this has become more well-known and more available online. And 6 of those 34 cases actually said in the journal articles that they purchased it online. But I'm kind of suspecting it's probably closer to 10. They just left it out of the journal article. So next slide. So case study number 1, this is a 40-year-old man. Dr. Alper presented this case at the Gita conference last year. 40-year-old took 2 grams of Ibogaine and 4 grams of some kind of booster purchased on the internet. And yeah, that's I had to quote that from the journal article. That's how they listed it, an uncharacterized booster. He was found 8 hours later, unresponsive, covered in vomit, and a flatline heart rhythm, which is the most terminal heart rhythm. You usually don't get people back from that. He actually was resuscitated. The ROSC is return of spontaneous circulation. He would, his pulse came back during his trip to the hospital. His QTC on admission was 588 milliseconds, which is very prolonged. Anything over about 450 range is problematic. And then I have written down somewhere, I think his QTC got worse. Maybe I don't have that. But on admission to the hospital, he was found to be in metabolic acidosis. His pupils were fixed and dilated. He had low blood pressure, requiring drugs to keep his blood pressure high, vasopressors. And he failed his apnea test, failed his brain perfusion scan, was declared brain dead, and support was withdrawn once brain death was confirmed. The ideal resuscitation for a heart starts before any permanent organ damage. There's a very narrow window to successfully resuscitate people. Generally, you need to be on top of it within the first 3 to 5 minutes, because at the 5 to 6 minute mark is when you start risking brain death. The amount of time, and this is another important part, you have to have defibrillators, you have to have electricity. The amount of time between the initial cardiac arrest and defibrillation is the single most important predictor of survival. The goal is to defibrillate a patient in less than 3 minutes. As a cath lab nurse, my goal was to defibrillate a patient in less than 1 minute, because we had the machine sitting there right beside the patient. And survival decreases by about 5% per minute of delayed defibrillation after that 3 minute mark. So you really don't have time to screw around when bad things happen. Next slide. That one, I'd have to look it up in the article. Mm-hmm. Managed to revive him. Okay. Right. Wow. I can double check I've got the articles with me today, so I'll check on you. This was a 2016 case, so this was last year. And then Dr. Alper presented on this one last year at the Gita conference. And he published the article on it, so I'll find that for you. Next slide. Oh, yeah. Sorry, I hadn't done the slide yet. So this is another case study. This was a 39-year-old self-administered 7 grams of Ibogaine. This is pointing out that these people often get very bad instructions from their online providers, or some of them even go on Facebook. I got this Ibogaine. How much should I take? And then they'll sit there and look at comments. You should take this much, and it's just a really bad idea to get your advice from social media, I think, or people on the phone that have no liability as to the outcome of your treatment. So this guy was another attempted heroin detox at home, no previous medical history, negative toxicology. He had 3 seizures 5 hours after ingestion, and he had had a similar event 4 months prior during the first Ibogaine use. This guy did actually survive this, so not all of the case studies are deaths. Some of them are hospitalizations, also always ICU stays. He had 8 episodes of pause-dependent torsades requiring transvenous pacing in the ICU. And transvenous pacing is something that when you need it yesterday. So proximity to a hospital with a cardiologist in-house all the time is extremely important as far as locations of Ibogaine centers, as far as your emergency planning. QT interval on admission, 640 milliseconds. On day 2, it peaked at 730 milliseconds, which I've never seen a QT interval that long. This was an interesting case because it actually published the 12-lead EKGs. So you could see how his pauses were causing the torsades. Basically, when the heart pauses, you have 3 pacemakers in the heart. So there's a primary pacemaker that drives the heart, the sinus, SA node, sinoatrial node. And if that pacemaker fails, one of the 2 lower pacemakers takes over. In his case, that pacemaker failed. The second, more functional pacemaker did not take over. The backup pacemaker from the ventricles took over, and he went straight into lethal cardiac arrhythmias. He was discharged by day 7. He had no electrolyte abnormalities. And before transvenous pacing, they tracked cardioversions, atropine, magnesium, and an isoprel drip. None of that helped. They had to go to transvenous pacing for this guy. So generally, when you get into an emergency, that's what's needed eventually in the majority of the emergencies that I've reviewed. Next case. I think so this was a 2016 case as well. The case study number 2 was 2015. Most of the self-administration cases are more recent cases. This was a 2016 case, and this was a female living in a caravan who bought powdered root bark online. Well, it was a powder labeled top quality Abernathy Ibogaine, or Iboga. She attempted to do a self-detox and was found unresponsive, dead in her caravan. History of polysubstance abuse, positive toxicology, only for benzos and cannabis in her blood or urine, but her hair analysis was positive for 11 different drugs of abuse. So there was obviously a remote history within the, I'm trying to remember how long hair analysis goes back, 6 months? Yeah, so she had 11 different drugs, and polysubstance abuse is a very complicated withdrawal because it's very unpredictable what the heart's going to do if you're withdrawing off of multiple substances at the same time. I've seen that in the ICUs in medical coma style detox. If someone comes in speedballing or something, their heart is all over the place as they're detoxing. It'll go from way high to way low to way high again. And then, so this was actually a journal in the forensic sciences. So they analyzed the powder, and it wasn't iboga. It was actually this other plant that I can't pronounce that's in the same that's in the same family as ibogaine. It's a more common, less expensive shrub. So obviously black market iboga salesmen are cutting their iboga with this stuff, which is also cardiotoxic. And the little small bullet is all the effects that it can produce in people, which is pretty serious, on up to coma, hypertension, bradycardia. It produces similar effects, but it has no therapeutic value. So this, even though the title says death, the title of this journal article was "Death Related to the Consumption of This Powder," mislabeled as Tabernathy iboga. And one of the quotes I liked from this article was that this, at the very end, in the conclusion of the article, they just said, "This case highlights the worldwide problem of counterfeit products available over the internet and the danger associated with their consumption." Obviously, it's very hard to trust that your things that you buy on the dark web are actually what they say they are, because there's no accountability in that mode of buying your stuff. Okay, next slide. Right. Yeah, I'm sure it's like just diluted down, cutting it with. Huge difference. Yeah, I mean, the only way to really truly know what you're getting is to get it from a GMP lab, or go to Africa and watch them shave it off a tree. Like, you know, that's really the only way to know what you're really getting. So, you know, which one is more practical? All right. Recommendations. Ordering iboga online and for self-administration is not safe. It's a big risk. It puts the provider and their sitter at risk, you know, or the patient, sorry, and their sitter. It sets up these sitters for secondary trauma, and, you know, they're trying to help their loved one get better, and unfortunately some of them watch their loved ones either go brain dead or die because of this, or get sent to the ICU. So due diligence is it's very imperative when you're choosing your setting, your provider. You need to ask a lot of questions and get a lot of, you know, research your medicine source. A provider should be able to show you paperwork from the GMP lab if that's where they get if that's where they say they get their ibogaine from. Ask lots of questions, and as always, buyer beware. You get what you pay for. Next slide. So this one is another hot topic in recent years. There's no risk if you low dose or microdose. This one's another one you'll hear a lot on social media. You know, people like, I can't afford to do a big fancy treatment out of the country, or I can't even leave the country, so I got this stuff online and I'm just going to microdose or take a low dose at home, or that kind of thing. While I do think that the concept of low dosing is a safer approach overall, I like that there are providers who are starting to do low dosing, but the patient still has to be screened as if they're going into a flood dose, because even at very low doses, if there's a pre-existing heart issue, it can trigger an event.